Okay, I'm going to get started. So welcome everybody. Thank you so much for joining us. This is the Island Medical Program Physician Education Programs, fourth session in our Island Dermatology series, and we're thrilled to have Dr. Copley here to talk about psoriasis. I know other people will keep joining, but we really want to be mindful of everybody's time and really appreciate you showing up in the evening to learn about some skin. I'm going to do a quick land acknowledgement for where I'm calling from, but also knowing that we're all calling in from different areas. It's my privilege to be calling in from Coast Salish Peoples Territory, but more specifically the Lekwungen speaking peoples, which includes the Songhees, the Wasanik, and the Esquimalt peoples. I know that I was looking at a recent paper that shows that Indigenous people struggle with dermatologic care and suffer from skin diseases, including psoriasis, at a higher level due to socioeconomic factors and access to medicine, clean water, and other variables. And I'll be keeping that in mind as we listen and learn today. I'm just going to have Leah tell you a little bit about Slido, and then I'll introduce Dr. Copley.
Sure. So welcome everybody. Tonight we are going to be having our lecture portion of it provided by Dr. Copley. And for the last 15 minutes or so, we are going to have a question and answer period. So we'll ask that you save your questions till that last 15 minutes just because we have a lot to get to. And for the questions, we're going to be using Slido. So in the chat, I just posted a link. If you click on that link and go to the Slido page, you can submit your questions there, and then we'll address them at the end of the lecture. Thanks all.
Great, thanks. Okay, well, here it goes. So I got a great introduction for Dr. Michael Copley. Michael is a super guy and amazing dermatologist. The word on the street has it. He's now working with Skincare West in Nanaimo, and he's completed an MD PhD at UBC and then a dermatology residency as well at the Department of Dermatology and Skin Science at UBC. He's also board certified both in the States and Canada. He likes a team-based approach when he works, and he's a clinical instructor with UBC Department of Dermatology and Skin Science. He's passionate about education in dermatology, and he teaches medical students and residents frequently. He has a particular interest in skin cancer, autoimmune disease of the skin, telemedicine. I happen to know he's a bit of an expert at rashes and weird rashes as well. And with that, thank you so much, Dr. Copley, and we'll hand it over to you.
Okay, thank you so much, Chris. You can hear me okay? Good. Okay, great. So yeah, it's my privilege to be presenting from Nanaimo. This is the traditional land of the Snanawas First Nations, and it's also a privilege to be presenting to you today. This is a long time coming. Chris has been chasing me down to be involved in this, and he persevered. I've been pretty busy and wanting to be involved in something like this. So my colleague Gabby Whitekert, she kind of reconnected with Chris, and then he and Gabby asked if I could be involved, and it's a real privilege to be presenting on psoriasis. So yeah, psoriasis is one of these topics that you learn quite a bit, but there's 2,000 other diseases in dermatology, so you focus on a lot of the rarer stuff during a residency. So you learn the most. I think I have learned the most in the last few years in clinical practice. And actually, what I wanted to share with you is sort of the privilege in the current era of biologics, advanced, even topical therapeutics, which we'll talk about. That actually engaging in care of patients with psoriasis is really rewarding, because I know that you, often the primary care physicians, I know there's a lot of GPs, family physicians out there, and I see you, and I've seen your referrals come my way, so it's nice to meet you. I know there's a lot of unsolvable problems out there, but I hope by the end of this, you'll realize that psoriasis is not one of them. So on that note, let's get started. So I have a number of disclosures. I do take part in advisory boards with a number of pharmaceutical companies, including companies that make psoriasis biologics and topicals. And I'm recently involved in some clinical trials for psoriasis medications. I'm also the president of the Doctors of BC section of dermatology. And those are my disclosures. So in terms of the objectives for today, I hope by the end of our talk that you should be able to distinguish the clinical features of plaque psoriasis, but also recognize the rare psoriasis subtypes, to outline the most important psoriasis comorbidities. And I particularly wanted to talk about this because these are issues that we will be co-managing with our patients. And again, I do rely on my primary care colleagues to help identify and address these comorbidities. And then thirdly, I want to talk about the initial management, and also I will get into a little bit of what I do when I see my patients with more moderate to severe, or your patients with moderate to severe psoriasis. So I'm a basic scientist at heart, and that's actually another reason I love psoriasis, because really it is translational research in action. So I think to really understand and to get excited about psoriasis and the therapeutics we have available, it's important to go back to the basics and understand what psoriasis is. And I always have my patients ask this: is this an autoimmune condition? The answer is yes. That's the same thing about eczema, and the answer is a little bit more questionable. That's a whole separate talk. But certainly this is an autoimmune disease, and it's a chronic disease that's characterized typically by red scaly plaques. And the pathogenesis is due to increased skin turnover. As you recall, learning the histology of the skin, there's a stratum basale, which is the lowest layer of the epidermis. And then there's maturation into ultimately the stratum corneum. Generally, that takes 30 days in healthy skin, but in psoriasis, it takes 4 days or even as little as 3 days. And that leads to an increased thickness of the skin. It leads to redness, and it leads to scaling. And the redness, again, to understand the pathogenesis is important, is due to vasodilation and increased vascular structures within the dermal papillae. So although it's a skin-limited condition, it's also a disease that can affect other systems, and the joints are the most important, with about 30% of patients with psoriasis getting psoriatic arthritis. So now to the real basic science. This is really where we're at with psoriasis right now. And it looks a little scary. We'll walk you through it. And it's important because what this does is it actually helps frame the treatments that you're seeing your patients on these days. So we think that what happens with psoriasis is there's a genetic background of some sort of predisposition. And then when there's injury to the keratinocytes through trauma, stress, there's a release of these DNA complexes which activate the immune system to upregulate important cytokines that lead to this maturation of this critical cell called myeloid dendritic cell. These then produce these critical mediators that are really only important in psoriasis and not really that important in too many other aspects of our immune system, to arguably fighting mycobacterial infections. We'll talk about that a bit later. This leads to upregulation again of these key cell types, Th1, Th17, Th22 cells, produce further cascades of important molecules, again, TNF alpha, IL-17, leading to, again, keratinocyte proliferation, increased skin thickness, and then redness due to vasodilation angiogenesis in these little, we call reedy ridges, or the dermal papillae coming up in between the reedy ridges. So now you know everything you ever needed to know about what psoriasis is. And really, all of these are critical targets for the biologic therapies that you see your patients on these days. And what we've moved from the TNF inhibitors, although they are still used, to these downstream effectors like IL-17 and IL-12 and 23. We'll talk about, with that, you can be highly specific and also highly efficacious. We can never cure this disease, but we can clear this disease, which is really exciting. So what are the causes? It's genetics, inflammation, environment, and then this leads to increased skin proliferation. This is sort of how one can understand the pathogenesis. Again, there's a strong component of a genetic predisposition. About 30 to 90% of patients have a positive family history. And there's certain HLA subtypes actually that track with a risk of psoriasis. Again, this leads to, then there's an environmental exposure. It can be infections, medications. Steroid withdrawal is an important point. And again, I'll talk about that later. But this is the reason if you think someone has psoriasis, and even if it's really bad, we really try to avoid psoriasis because it might make it better, but steroids, it might make it better, but as soon as you stop it, it could flare their psoriasis. This ultimately leads to inflammation. Stress keratinocytes release these DNA and RNA complexes, and then they cause this release of these really important critical mediators. This again leads to this increased skin proliferation, hyperproliferation. So this is a disease that affects adults almost principally. It does occur in kids, but very rarely. The major onset is bimodal. There's a 20 to 30 year peak, and then again, 50 to 60 years of age. So it's not uncommon for me to see patients well past their 60s presenting for the first time with psoriasis. So just because someone's elderly doesn't mean they may not have psoriasis. So worldwide prevalence is about 2%, but in Canada and the US, it's about 5%. And about 80% of patients report a significant negative impact. So what are the factors of their lives that are affected? Self-esteem, social activities, and as well as a lot of psychosocial issues with anxiety, depression, interrupted loss of sleep, missed work, among others. So this is a disease that it's just on the skin. And again, it truly is, in almost all cases, not a life-threatening problem, but it is a quality of life issue in almost all cases. So comorbidities are a critical thing that has been starting to be understood more and more in the last several decades. We used to think psoriatic arthritis, maybe obesity are associated, but this is a list, and this is a short list of diseases that have been associated with psoriasis. So again, psoriatic arthritis is probably the most common. About 30% of patients with psoriasis will have comorbid psoriatic arthritis. But again, cardiovascular and metabolic disease are also very prevalent. Gastrointestinal disease, including inflammatory bowel disease, psychiatric comorbidities, even respiratory and substance use comorbidities. I want to talk about psoriatic arthritis just for a few minutes. I'm certainly not a rheumatologist. I do lean on my rheumatology colleagues for this, but I also do screen my patients. And I think this is a really important thing for you to be considering as well. So psoriatic arthritis is a seronegative inflammatory arthritis, meaning it's rheumatoid factor negative, but it can be destructive, just like rheumatoid arthritis. There's about 5 different forms, so it doesn't always just affect the back. So it's not just an axial disease. It's not just small joints of the hands. It can actually have these 5 different forms. And then a tool which has been validated to screen, and it's one actually I've entered into my EMR. You can make a little macro. Is something called the Psoriasis Epidemiology Screening Tool, or PEST tool. It asks these 5 questions, and if they score 3 or more out of 5, then this patient does require a workup or referral to rheumatology. The questions are: have you ever had a swollen joint or joints? Has a doctor ever told you have arthritis? Your fingernails or toenails have holes or pits? Have you pain in your heel? And that's a question for enthesitis. And have you ever had a finger or toe that was completely swollen and painful for no apparent reason? That's a screening question for dactylitis. So again, comorbidities, there's a lot to go on here. And I do not and cannot screen for all these comorbidities. But these are the probably comprehensive list. And here are some of the things that you can do to help screen for these diseases. And again, some of them are, things that can be reversible and addressed, tobacco consumption, alcohol consumption, and then others are ones that are comorbid that are important to identify. We're still trying to understand how much a role treating psoriasis, particularly with systemic therapies, plays a role in terms of addressing these comorbidities, but certainly there's a lot of cases where it does. So how do you make the diagnosis? And again, Chris has mentioned at the beginning that I'm really excited about morphology and diagnosis, because I really do think we're getting better and better resources these days in terms of up-to-date visual DX, et cetera. And once you know the diagnosis, you can look up the treatment. And that's changing all the time. But when the diagnosis is wrong, then of course the management is going to be wrong. So I do want to spend a little bit of time here talking about the diagnosis and differential diagnosis from a morphologic standpoint. So sure, plaque psoriasis is the most common presentation, and most of us can recognize that really well. These are well-demarcated pink to red plaques with what we call a micaceous or silvery scale. There's other types of morphology which are quite distinctive. Guttate psoriasis, again, also red and scaly, but very small papules, symmetrically distributed to the trunk. Inverse or genital psoriasis, these are well-demarcated, sometimes moist pink plaques, often with variable scale. And then nail psoriasis has a whole separate set of findings altogether. Now, distribution is also a really important factor. The distribution of psoriasis is also a clue, but it's not sort of enough to make the diagnosis on its own. But if you see something that looks like it might be psoriasis, what I do is screen for what I call the hot spots. That'd be the scalp, extensor elbows, extensor knees, genitalia, and umbilicus. And if you see that, that helps actually support the diagnosis. Another, not pathognomonic, but important clue is the Koebner phenomenon. And that's any injury can trigger this process. This is a case shown here in this picture of a patient that had zoster, had persistent redness and scaling at this site, and it turned out to be psoriasis. This also occurs in lichen planus, vitiligo, and another phenomenon called halo nevi. Auschwitz sign is another sign. This is where when you remove the scale, and I don't typically do this, but often the patient has already removed their own scale, and you'll see the punctate bleeding. It's actually a manifestation of those dermal papillae that I was telling you about at the beginning. So again, the basic science is important. So that punctate bleeding is an important clue to psoriasis. But when you see psoriasis, you have to think of the differential diagnosis. So this is my differential diagnosis for psoriasis. You don't need to know all of this, but it is important to consider broad categories of diseases. Now, in dermatology, we talk about things being papulosquamous. That means red and scaly. Essentially, this is the papulosquamous differential diagnosis. And there's three broad categories of papulosquamous disease. That's psoriasis, pityriasis, and lichenoid. So psoriasiform things, I break down infectious, inflammatory, neoplastic. These are all things that you should be considering on the differential diagnosis. But practically, there's actually quite a short list. And I like to use this little mnemonic that I did, I think I did teach about at my last talk. So I'm sorry if this is repetition, but I think mnemonics are a nice way to approach rashes, because I find often non-dermatologists look at a rash and say, and call it morbilliform, or just call it a red rash. But really, the joy of dermatology is looking at the features that the skin is giving you and coming up with the differential diagnosis. So a red and scaly rash, the differential diagnosis is actually not that broad. And I've come up with this mnemonic PEP-POM. So this is psoriasis, eczema, tinea. These are the three most common. And in POM, if you're not thinking it's any of those three, these are less common. So just think of your pet standing by a palm tree. There's the pityriases, the annular erythemas, the L's, the lichen planus, lupus, and light eruption and luz, as well as mycosis fungoides, which is very important. Eczema, ill-defined erythematous, often exudative plaques. These are often on flexural surfaces instead of extensor surfaces. tinea, red and scaly, but often an annular formation with this colorative scale. Pityriasis, Pityriasis rosea has a herald patch. There's also Pityriasis versicolor, which is these little red to brown, sometimes hypopigmented papules and plaques. And then Pityriasis rubipilaris is much rarer, but important one to have on your differential diagnosis. And the distinctive feature here is instead of these being individual plaques, these are plaques with sparing. So we call these islands of sparing, where there's some disease sparing, but mostly it almost encircles these areas. The annular erythemas are much rarer, but the most important one to know about is erythema annularis centrifugum. Also has a colorative scale. And then lichen planus is actually one that I find people often forget about. This would often be on the dorsal ankles, shins, and they be these flat-topped, polygonal, purple, peritic papules. And they look in the mouth, they'll have Wickham striae. The L's are lupus luz and light eruption, discoid lupus, subacute cutaneous lupus, polymorphous light eruption, and luz is old name for syphilis. And then mycosis fungoides, I'll stop here because this is a really, really important differential diagnosis. If you have a patient that's elderly, has eczematous or psoriasis-like plaques, and your treatment is just not improving, or if they initially present with a bathing trunk distribution of their plaques, that is almost exclusively on sun-protected areas, buttocks, flank, lower back, and then you look closely at these plaques and they have this fine wrinkling, we call it cigarette paper wrinkling, you must be considering a condition called mycosis fungoides, which is the most common form of cutaneous T-cell lymphoma. Again, this talk is not about that. It's about psoriasis, but this condition does respond to topical steroids, but not as well as psoriasis or eczema, and looks different. A biopsy has to be done in those cases. So I want to move on to psoriasis subtypes. So again, the most common type is plaque psoriasis or psoriasis vulgaris is another name for it. But also you can break it down to distribution variants or other subtypes. The distribution would be nail, genital, scalp, or palmoplantar, and the other types would be generalized pustular, guttate, or erythrodermic. So plaque psoriasis, we can all recognize this, but these are sharply demarcated, elevated plaques, often with prominent scalp involvement, with this micaceous, so it looks like mica, or silvery scale. Nail psoriasis has findings actually very similar to onychomycosis or nail fungus. Distinguishing features can be the fingernail prominent involvement as well as symmetric involvement. But actually both psoriasis and onychomycosis share distal onycholysis, subungual hyperkeratosis, but oil drop sign and splinter hemorrhages would be more common in psoriasis. Guttate psoriasis. This is quite a rare, but typically initial form of psoriasis. This is a patient that has never had psoriasis before, typically a child or a young adult. They present normally several weeks after a group A strep infection, typically strep throat, and they have widespread papules with scale. Sometimes they are completely asymptomatic to their strep throat. Sometimes it's perianal strep, particularly in young children. These patients can be reassured this typically will go away, but in rare cases, about 25% of cases, this is the sort of the first presentation of psoriasis. Now, pustular psoriasis doesn't look like psoriasis at all. And it's actually a really important finding because this is a kind of psoriasis that although it's not typically life-threatening, these patients can be very sick and sometimes will require hospitalization or at least close monitoring. That's because these patients can have systemic symptoms, including fever, chills, sweats, as well as insensible losses due to the extensive body surface area involvement. There's generalized, that's a generalized form, but the more common form of pustular psoriasis is something called palmoplantar pustulosis. There's studded pustules, as well as these red-brown macules on the palms and feet. Now, features that might lean you toward this one or factors would be This is more common in pregnant patients, and this is the kind that happens with abrupt steroid cessation. Now, erythroderma can be caused by psoriasis. Erythroderma just means red scaly skin over 90% of your body. It is a broad differential again, but psoriasis is probably the most common cause. And so in these patients, you ask about a history of psoriasis, also examine their nails and ask them. And then look at the scalp. And these might be clues that their erythroderma is actually erythrodermic psoriasis. So severity classification is something that mostly dermatologists do, but it is an important thing to get used to because it helps guide you in terms of deciding whether to refer and deciding what your treatments are going to be. So this is broadly the way we categorize psoriasis. That's mild, moderate, and severe. Now, the easiest way is by body surface area involvement, and I'll talk about how we assess that next. But less than 3% we consider mild, moderate is 3 to 10% body surface area, and severe is 10%. And it's really important to be deliberate about doing these assessments because there's been studies showing that people grossly overestimate the body surface area. There's also other methods like the Physician Global Assessment and PASI score. These are ones that are typically only done by dermatologists. These are the three main ways you can assess the body surface area. You can use the rule of hand, and that's the simplest. You close your hand and put your fingers together. That's 1% of that patient's body surface area. The rule of nines, we all know from learning about burn management. And it's sort of a simpler version of this, I call the 10, 20, 30, 40 rule. And it's basically the head and neck, upper limbs, trunk, and lower limbs are 10, 20, 30, and 40% respectively. Now, patient-reported scoring system is also really important, and the most common one we use is the Dermatology Life Quality Index, DLQI. I won't get into it entirely, but it actually looks at the impact on the patient specifically. So how do we manage? Well, I tell my patients, we can treat or we don't need to treat. And it really depends on how much this is impacting you. Now, often patients are like, I don't really care that much. But then you talk a little more about the treatment, and they say, well, maybe I will, because I don't take my shirt off at the pool. Or it's kind of annoying having all this scale around the house. Some other patients have one little plaque, and they're mortified. They think it's disgusting, it's really itchy, or the symptoms are just very severe. Again, a sort of misnomer, I think it's something I learned in medical school initially, was that the psoriasis is not itchy and eczema is. Well, psoriasis can be very itchy, and it's a significant quality of life issue. How do you break down the management? Education, you address lifestyle factors, and talk about topical, phototherapy, and systemic therapies. How those overlap with severity is more or less like this. Mild disease, I do always offer topical therapy. We also want to always be addressing medical, non-medical lifestyle factors. If it's not getting better or it's moderate or tending towards severe, consider phototherapy as well as systemic therapy. So when I talk to my patients, I say this is a chronic but benign skin condition that can be managed but not cured. I say it's similar to like type 1 diabetes. It's not contagious. And it's important to just say that explicitly because everyone always thinks that almost everything is infectious, but this is not. It can affect the joints. There are certain triggers that can contribute or worsen to the disease, but that's a lot different than those being the cause of the disease. So I do reassure my patients, this is not your fault. It just happened. There are factors that can help make it better, but they probably won't make it go away entirely. And the treatments can be reactive or proactive. So identify the triggers, and stress is one. Again, reassure my patients, like we probably can't address all your stress, but you can do things to try to lower that stress. But also I find by treating the disease, their stress lowers, and that can help in the whole cycle. Try to address alcohol consumption, which if it's excessive can be a factor. Cigarette smoking is an important trigger. And certain drugs are known triggers, but certainly not causes unto themselves. Then modifiable risk factors, again, would be these. And then how do you break down the topical therapies? There's about, again, 9 different classes here. The main one would be topical steroids, then vitamin D analogs, and combination therapies with vitamin D analogs and topical steroids. And there's calcineurin inhibitors, which are considered off-label. Anthralin, which basically is not used anymore. Topical coal tar, LCD, and then topical retinoids like tazarotene specifically, and salicylic acid, and a new medication called roflumilast. So again, I could do the whole talk on just topicals, but I'm not going to, because really this is a changing landscape, and these are actually really, really good guidelines that I found while preparing this talk. I'm not going to go through them entirely, but I will go through them at a sort of high level, so you could use them, and they're available on the AAD website to anyone. So if the patient has mild to moderate psoriasis, then they definitely should be treated. And are you considering topical therapy or consider phototherapy? Well, the answer is no. Or are you considering a systemic therapy? If so, then they still probably do need topical therapies as an adjunctive measure. If you're just considering topicals alone, basically, if there's plaques that are thick on the body, so not on the face, armpits, or genitals, you do want to use so class 1 to 5 means like medium to a very high potency. It's not really any point messing around with hydrocortisone or even like betaderm cream is going to be too low potency. Alicum, clobetasol, and I'll give you some examples in the next site. Now, if we're talking about sensitive areas, face, intertriginous areas, or areas that could be thinned through the chronic use of steroids, you basically want to be considering non-steroid options. Scalp psoriasis, you can use any potency, but I find medium to high potency are most effective. And then, topical steroids should still be used in patients on biologic and systemics. Again, facial psoriasis, Dovonex, or calcipotriol is a non-steroid. That's sort of the classic non-steroid. Again, as off-label treatment, we're often using calcineurin inhibitors. So tacrolimus would be the most common. And then these are often combined with topical steroids, and that and there used to be branded products, and now these are generics. Moisturizer are always important, and then coal tar is something that's available over the counter in tar-based shampoos, like Neutrogena T-Gel. There's another one called Sebcure. And then tazarotene is a relatively newer topical retinoid, something called I won't say the brand name, but yeah, it's a combination of halobetasol with tazarotene. That's a foam. And then salicylic acid is often combined with a high potency topical steroid, and that's particularly helpful in cases of very thick psoriasis. So the newest kid on the block is topical roflumilast cream. This is a non-steroid, and it's actually sort of a cousin of apremilast, which used to be and still is a systemic therapy for psoriasis, but not a very good one. Now, this is probably as effective as the oral apremilast, but is topical. As you see here, this data was from the Dermis-1 trial of topical roflumilast, showing that patients had IGA success, that is their sort of overall assessment of severity was 0 or 1, which basically means clear or almost clear skin. Up to 50% of patients, even after short periods of time, had almost clear skin, whereas in placebo, almost, very, very, very low number, like less than 10% did. And the good thing about this one is it's useful for any body site. And so it's kind of a one size fits all. Very well tolerated, indicated for cases 12 and older, and then a few side effects which are in keeping with this class of medications, probably due to some systemic absorption, are diarrhea, headache, and insomnia. This is most common in patients that are using on a very large body surface area. That's typically more than 25% body surface area. So what are take-home points for the topical therapy? Again, topical steroids are still a mainstay of treatment, but you want to use at least a medium or high potency, betamethasone or clobetasol, ointment or cream. Combination, betamethasone dipropionate and calcipotriene. This is a very classic combination. Of note, the gel is the only formulation that is covered under pharmacare. So you definitely want to make sure that you're writing gel instead of ointment or cream, which are much more expensive to most patients. Now, foam is not covered, but it's a very effective and actually slightly superior formulation. But not all patients can afford that, or their private coverage won't cover it. Halobetasol plus tazarotene is also very effective, and roflumilast cream. So for sensitive areas, that's the face, genitals, the calcineurin inhibitors, that's tacrolimus or pimecrolimus, and roflumilast, and then scalp, clobetasol lotion is typically my go-to. You can use a slightly lower potency like Helicom. And then fluocinolone oil is also very effective and quite a little lower potency. So some tips and tricks. The fluocinolone oil, although it's lower potency, it can be kind of massaged into the scalp, and that will help release some of the really thick keratotic scale. Hyperkeratotic hand and foot psoriasis, you can use a combination beta-methylene dipropionate with salicylic acid. This is a fairly new product here, halobetasol plus tazarotene lotion. It's particularly good on thick psoriatic plaques, but you only want to get the patient to apply it on the lesion itself and leave the surrounding skin alone, as it can cause quite a bit of irritation. And then consider proactive treatment. So I tell the patients that once their psoriasis is clear, this is an immune system problem, and so the skin has memory. So you have to continue to treat that area for an additional twice a week for an additional 2-3 months to keep the psoriasis away. Otherwise, you get a rebound effect. And then if patients have private coverage, the topical roflumilast is a great option. So phototherapy is something that's a great adjunct to topicals, but it should be used in addition to and not on its own. So narrowband UVB phototherapy is a very safe and effective treatment. It's available in many different sites on Vancouver Island. And the adverse effect profile is generally quite minimal and can be avoided with careful dosing. The treatment regimens are typically 2 to 3 times weekly, and my understanding is that anyone can refer to most phototherapy units, so you don't need to refer to a dermatologist to then refer to phototherapy if you're comfortable with that. It's compatible with almost all psoriasis biologics and systemics, except for cyclosporin. Oral agents for psoriasis, again, this is a whole talk unto itself, but the classical oral agents are here, and the main ones are used are methotrexate and cyclosporin, with acitretin reserved typically for cases like pustular psoriasis. And then deucravacitinib is a new oral medication, which is typically only available to people through private coverage and through a dermatologist. So the biologic therapies, and here's your up-to-date list of biologic therapies. And how do you choose, or how do I choose the right biologic for my patients? Well, there's many factors, and that includes access and coverage are probably the most important ones. But ideally, you want to find the safest and most efficacious agent. And then comorbidities are also an important factor. So if they have psoriatic arthritis, an anti-IL-17 agent or an anti-TNF agent are probably the top choices because they have been proven to be most efficacious. But acitretin and cyclosporin are probably not that effective. If they have comorbid inflammatory bowel disease, TNFs and IL-23s are preferred because IL-17s actually have been shown in certain cases to trigger inflammatory bowel disease. And if they're pregnant or planning pregnancy, this one specific version of an anti-TNF called certolizumab pegol has been shown to not cross the placenta and actually was studied in pregnancy. So it's definitely the safest option there. Contraindications, generally, although this list looks big and scary, there's not that many of them. And that would be basically severe untreated infections or known active or latent TB. But they actually can even be given the psoriasis biologic if they're treated for at least 2 months prior to starting. Crohn's disease, particularly for IL-17 inhibitors, or severe heart failure, is typically only for the anti-TNFs. Now, relative contraindications, these are people that I do start on psoriasis biologics, but have a discussion about the potential risks. So what are the best biologics? It's these ones, and these are the ones that cluster as being the most effective and with the lowest side effect profile. And if you see, these numbers are really quite astounding. So the PASI 75 is a score showing 75% improvement at 16 weeks. We also use a PASI 90. Again, risankizumab is probably one of the most efficacious agents right now. These patients, 90% of patients are more than 75% better, but a lot of these patients have PASI 100, meaning their skin is completely clear. And guselkumab, ixekizumab, secukinumab, brodalumab, and infliximab are the other most effective agents. Again, which ones are under formulary of BC Pharmacare? Shorter list, but also some very effective agents. But what's required for me to get a patient on a biologic? They have to be 18 or older. They have to have a BSA of at least 10%, or significant involvement of face, hands, feet, or genitals. They have to fail to respond or intolerant to phototherapy. They have to have a high baseline PASI score, and then they have to fail both methotrexate and cyclosporin. So these are really some of the strictest, unfortunately, for our patients, criteria in all of Canada. So there is quite a lot that the patient has to go through to access psoriasis biologics. Once they're on those medications, they're secured ideally for lifetime, which is great. But it is important for your patients to understand that they're going to have to trial for at least 3 months these two agents unless there is a contraindication. How do I work the patient up prior to starting a biologic? I want to screen for relevant contraindications, rule out latent infections, and then make sure that immunizations are up to date. That's, again, something that is very helpful if you're referring these patients to let me know that their immunizations are up to date. If they're not, ensure that they are. So when do you refer to dermatology? Generally patients with mild uncomplicated psoriasis with limited body surface area, first or second line therapies can be used, and that can be done under the care of the primary care provider. It's cases where there's inadequate response to first and second line therapies, severe rapidly progressive disease, or in challenging to treat sites like scalp, face, hands, and feet, or if they have these strange and severe subtypes like erythroderma or pustular psoriasis. If you're really uncertain of the diagnosis, that's another good time to refer. And in certain cases, they'll have to refer to us to offer phototherapy. So how do you co-manage a patient on a psoriasis biologic? Again, I'm happy if you're seeing the patient in between the times I'm seeing them for annual review to update their topicals. They might still have a little residual psoriasis. Make sure their immunizations remain up to date. They should have not received live vaccines, but any other vaccines are completely safe. And they should be given, actually, ideally 2 weeks before or after the psoriasis biologic. Now, this is an important point that is a very rare situation, but I did want to talk about this in this audience. If a child is born to a mother that was taking a biologic throughout the entire pregnancy, this does, unless it's certolizumab, Pegol, transfer, and so the child would have a small amount of residual biologic in their circulation, which means that child for the first 6 months of life, live vaccines are also contraindicated. And probably the most pertinent one would be rotavirus. There's some studies recently to suggest that this may not be as important, particularly with rota, but it is a precaution. And then long-acting biologics, these are ones that we're typically starting these patients on. They're given every 2 months, every 3 months. These are ones that can be stopped if needed and restarted if the patient has a reason to stop. So I think we're okay for time. Yeah, good. So I know it's a bit of a whirlwind. There's a lot to cover. But yeah, psoriasis really is a disease that affects 1 in 20 of your patients. And this is a disease that can and should be addressed. Comorbidities are prevalent and should also be addressed. And then mild or moderate psoriasis typically can be managed with topicals, but phototherapy is often a good adjunctive measure. And systemic therapies are actually very satisfying for both the patient and the provider if you can get the patient there, particularly for severe cases, and because they really can be sort of life-changing treatment. So with that, I'll give you some websites to these 3 key links that I was sort of referring to throughout this talk. Again, the clinical guidelines that I was talking about are here. DermNet is where I got most of my clinical images, and I encourage you to give resources to both your patients as well as use it yourself because I find it's actually a very effective and useful resource. And then the mnemonic that I came up with, the pet palm mnemonic, was actually adapted from this dermatologist's website, which, if you're really keen to learn more morphology, I think is a great place to start. He has a whole bunch of mnemonics for different morphologies in dermatology. So with that, I'm happy to take any questions, and also happy to take questions by email. Thank you.
Fantastic. Thanks so much, Michael. I'm just struck by how, as science has evolved, the treatment and therapies have become so much more numerous and perhaps a little bit overwhelming. You're incredibly impressive how you can read all those names and say them out loud. I don't even try. But thanks so much. So we have 3 questions in Slido.
Okay.
And anybody else, if you want to fire them in, that would be great. The first one is a nice one. I like it. How do you manage plaques within the ear canal?
Oh, it's a good question. Yeah. So I did not talk about that. So, you know, so first of all, I typically do refer these patients to otolaryngology because I can't look in the ear canal. Now, I think lots of you are comfortable with an otoscope, so you might be able to look. But I'll peek, and if I see psoriasis kind of peeking out, well demarcated plaque, and if psoriasis elsewhere, I'll assume it is psoriasis. And I find fluocinolone ear drops are actually the most effective treatment in my experience. And again, I kind of shied away from brand names. Are we allowed to say them here? Is that okay? I think
Yes,
it's like,
you
yeah,
can.
okay.
You can.
Okay.
Yeah.
Okay, yeah. So I think it's called Dermotic eardrops, and 1 or 2 drops allow it to fall into the ear canal, and do that daily for 4 to 6 weeks or twice daily. That can be very effective. If it's not particularly deep into the ear canal, just near the sort of the conical bowl at the entrance, you can use topical steroids, Dovobat, or medium potency topical steroid, just cream or ointment, just on a Q-tip, but you have to tell them to very carefully apply it, just with the tip.
That's right. Be careful with those Q-tips, or we get
Yeah.
to pull the fuzz out of their ears in the emergency room. Okay, how do you decide when a patient requires systemic therapy, and then how best to access these treatments? So I know you touched on this a bit, but maybe just sort of refresh us a little bit. How do you decide when they need systemic, and how best access this treatment?
Yeah, so I mean, the 2 main reasons would be psoriasis that's severe or moderate to severe, where I just don't think that topicals or even phototherapy is going to cut it, or psoriasis that has been treatment resistant, and that's typically resistant to both topicals and phototherapy. And that's for 2 reasons. One, these have more side effects, and so you just can't justify it if they have very mild psoriasis that's not impacting them for any potential harms. But 2, for access, both through BC Pharmacare as well as through private coverage, patients do need to have failed and have documented that failure, appropriate topicals and phototherapy, unless there are access issues. So if a patient is in a community where there is no phototherapy within a reasonable distance, then that's not a criteria that's required. So that's basically how I decide.
And who can prescribe them?
Yeah, it's a great question. So anyone can prescribe any of the systemics I discussed: methotrexate, cyclosporin, acitretin. I find there are some family physicians that I've encountered that are comfortable prescribing methotrexate in particular. And I agree. I think it's a very safe medication that has quite a low side effect profile. And if you want to start a patient on methotrexate, that's completely fine. Cyclosporin, it's also very effective, maybe not quite as clean a drug in terms of side effect profile. And then acitretin is actually if you're comfortable prescribing Accutane or isotretinoin, then acitretin is essentially the same side effect profile. Actually, I find it's better tolerated The only one with the only interesting sort of specific test that you also have to order would be TSH, because it sometimes can interfere with thyroid levels. So in terms of biologics, if you go the traditional route, and that is through pharmacare, only a dermatologist can prescribe psoriasis biologics and have it covered by BC Pharmacare. But there are cases, but if you're getting it through private coverage, patients, Canada Life or Green Shield, then anyone can prescribe it. So if that's something you wanted to gain the experience to do, I don't think that's a bad thing. And I think we're going to have more and more. I think these drugs are going to get less and less expensive as they become off. They become generic. And so more and more, I think private coverage will be expanded. And I think there'll be more opportunities for non-dermatologists to prescribe.
Excellent, great. And following along that, we have a question. What are the cheapest first-line topicals?
That's a good question. So the topical corticosteroids are definitely the least expensive. And so that would be, moderate areas on the body, betamethasone valerate, 0.1% ointment, cream, but again, ointment's better. Actually, that's a good important point I like to bring up. I had a lot of patients who are prescribed creams because they're better tolerated, but actually due to the kinetics of transdermal delivery of drug delivery, due to the hydrophobic nature of steroids, a ointment base is actually about 10 times more potent. So I often have patients come in off with eczema that are on betamethasone valerate cream, and I just switch them over Betaderm ointment. And I have to explain to them that this is actually a 10 times more potent medication just based on the vehicle that it's in. So certainly topical steroids are the least expensive. But Dovobet gel, and again, that's generic now. So betamethasone dipropionate with calcipotriol is also covered under pharmacare. So although it is quite expensive, if the patient has reached their deductible and is covered with pharmacare, then it's not expensive for that patient. And then, unfortunately, the calcipotriol on its own, is really expensive, like ridiculously expensive. And they come in very large tubes, like 120 grams. They're over $200. So although it's a good option, it's best to use it in the formulation of the combination with the betamethasone dipropionate, because there's coverage. And then other less expensive ones, like if you compound some things like salicylic acid, so diprosalic, which is betamethasone dipropionate with salicylic acid, it's not particularly expensive. Then you can even compound in LCD, which stands for liquor coal distillate, which is tar, LCD, compounded between 6 and 10%. You can add that to either clobetasol on its own, or clobetasol plus salicylic acid. I think it's about 5%, plus LCD 6%. Now, compounding is variably expensive, so sometimes it's inexpensive, but a lot of pharmacists charge a lot for compounding. So those sometimes are less expensive than these new fancy non-steroidal topicals, but they'll still be much more expensive than just the plain topical steroids.
Awesome, thanks. Okay, we got 2 more questions now. So
okay.
if a patient's not bothered at the start with their classic elbow plaques, do you still recommend topical treatment to avoid those supremely thickened plaques over time?
Yeah, I mean, no, I don't necessarily. So I don't think we know enough about the sort of natural history that all plaques are destined to get really thick. I think some patients and in fact, there's a subtype of psoriasis where often an initial presentation called ostraceous psoriasis, which I didn't even talk about. But that means like oyster shell-like, and it's just so thick that it looks like these oyster shells. But I think it has more to do with the biology of that individual's psoriasis as opposed to it just being neglected for too long. So I tell my patients, particularly if they present first time with psoriasis, and typically that's in the scalp, I don't think there's too much evidence or any evidence as far as I'm aware that like topicals are disease modifying medications. So I don't think treating versus not treating is going to change the natural history based on my understanding of the current literature. So long story short, no, they don't need to treat it if it's not bothered by it. It's not
Great.
bothered by it.
Excellent. Okay, great answer. Okay, so the last thing, we have a couple of themes about phototherapy. So Tracy put in the chat that you need a dermatologist referral for light therapy at RJH, even for
Really?
returning folks. And then the
Yeah,
question
I
in the
think that is a new policy, which I think is a change because they don't have a dermatologist overseeing the phototherapy unit there, I think, anymore, which used to be the case. So that's
I see.
unfortunate.
And then there's another question in the chat. Do we have private phototherapy in Victoria or alternatives to the RGH clinic? Is there
Mm.
dermatologists that have phototherapy services?
Yes. So I think most dermatologists in Victoria, from my recollection, Sakina Rossi, Patrizia Moccia, I don't think Tatiana Hamilton, Rudolph Kruger, they definitely all have phototherapy. But I think they do not provide phototherapy to other people's patients. They have to be referred, seen by a dermatologist, and there has to be a decision to treat or not. So it's a little bit different up island, where Dr. Herselman and Heusman, they're family doctors in Qualicum. They run 4 different phototherapy units, one in Port Alberni, Campbell River, Qualicum, and Comox. And my understanding is that they accept referrals from anyone to start phototherapy, but they might, if the referral comes from a family doctor, they might also need to see the patient first, I think. But I still think you can still refer the patient and get them started without them having to wait a year to see a dermatologist.
Amazing.
Oh yeah, there's also in Duncan, for folks that are in Duncan, Dan Phillipson has a unit near the hospital. He's a family doctor as well.
Great. Great. Thanks. I think we're right on time to wrap up. So
Great.
those that maybe didn't want to use Slido, you can shout out a question if you have it. Otherwise, we're going to say goodbye for the evening. Okay. Well, that's
Thank you
great.
everyone for
Thanks.
your attention, and if you didn't miss dinner, I hope you had some nourishing education.
Yeah, and thank you, Michael. That was excellent. Very great.
Okay, my pleasure.
Have a good night, everybody.
Okay, bye-bye.